and welcome to the 4th Annual Palliative Care Conference of UC Davis Medical Center. I just want to give a shout out to Dr. Quy Tran, who brought all of these extraordinary speakers together with all of you. This is really wonderful to see so many people. Thank you. Thank you, Quy. So it's my great honor to introduce to you Dr. David Steinhorn, who is here from Washington, D.C., where he's the medical director of the Children's Palliative Care program at Children's National Medical Center. He wears many hats. As a researcher, he has published over 50 articles. As a pioneer, he has at least 100 textbook chapters. As a teacher and mentor, he has helped and guided thousands of medical students, residents, and fellows, including me when he was a professor of pediatrics and palliative care here at UC Davis a few years ago. Today, he's here with his colleague, who Jana, who just spoke just a minute ago. I best think of Jana as Superwoman because underneath that mild-mannered exterior as a child development teacher at Galt High School, she is the co-founder of the Tao Wellness Center in Sacramento and director of the center, as well as a shamanistic healing practitioner. And I really hope you get to experience some of her superpowers today. So it's my great honor to introduce Dr. David Steinhorn. Please give him a big round of applause.
All right. I'd like to thank Dr. Tran for inviting me here. The last time he asked me to give a talk was at a VA hospital on bioethics about 5 years ago or something like that. This is not going to be a pediatric talk, although it does have relevance for pediatrics because, as you'll see from some of the slides, the fastest growing segment of the homeless population are families, and most of these families have children and lack a residence. This is the usual disclaimer to cover us, and I like this quote from Schopenhauer. Because I think that this really looks at how we look at what we're trying to do. This idea that the homeless don't want or need sympathy or pity, but they need compassion. And if you think about what the root of the word compassion is, it goes back to the Latin, which means suffering with someone else. The German word is Mitleid. Leiden is to suffer, and is to suffer with. So that what we're really talking about is seeing these other people as more equal to us rather than different from us. And I think that these are important things as we look at the concept of who the homeless are and what our relationship to them should be. Homeless can be, by one definition, individuals and families who lack a fixed place to sleep on a regular basis at night. And there are the temporary homeless, those who are fleeing domestic violence, finishing their education, such as the Stanford students who are living in rental RVs, for example, because it's so expensive to live in Palo Alto, released from prison, patients with mental health problems, etc., constitute the more chronic homeless population who cannot find their way to living in society as most of us are able to do. There are a wide range of the different homeless, and this is partly from a presentation that Marlene did. I've been in touch with Marlene. Actually, I met her in 2013 when I was here because of her work with Southeast Asian women's healthcare issues when she was still on faculty at UC Davis, and we've maintained contact since then and increased it since the Joshua House initiative was started. All societies have had homeless people. This is something that's well known. If you go back into classical Greek mythology and ancient Greece, there were the homeless people, the beggars, and these people were often people who were either mentally ill or had other physical deformities such that they couldn't function normally in society. And one of the concepts in ancient Greece was that you had to be kind to these people, you had to be kind and compassionate with them, you had to be generous and charitable, because these might have been gods who came down to earth and took on the form of these disabled individuals, these apparently crazy individuals, and you wouldn't want to offend one of the gods by being mean to them. So people who were homeless, who had these other sorts of physical disabilities, took on a special place in Greek society. And so there's a long history throughout Western civilization of focus on who these people are, their place in society, and I think that that our contemporary 20th century and later life in the industrialized society cultures doesn't really value or appreciate the homeless or those who can't be productive, those who aren't attractive and thin, those who aren't physically fit and incapable, and we look at people as others. It gets back to a tribal kind of concept of things. If you're not like me, then you're a foreigner and you're somebody who I reject. And I think that we in palliative care have opportunities to work with these patients and families in the case of the homeless with children in a very different way. In the late 1970s, a lot of the mental institutions that were supported by public funds were downsized, and a lot of patients with mental illness were released into the public, and these became a significant segment of the homeless population that we deal with. And as Jana mentioned, the homeless represent not only those who have suffered natural disasters, whether it's Katrina in New Orleans, the hurricane in Puerto Rico a year ago, the Santa Rosa, the fires here, for example, or those who are fleeing warfare and just for the sake of surviving have to leave their home with what they can carry and try and feed their children and protect themselves. So there's a wide range of people who would be considered homeless, and I think we shouldn't ignore that fact that but for the grace of God, as we always say, there go I. And any one of us could find ourselves through warfare or other sorts of unfortunate circumstances in difficult straits. These are estimates about of the homeless in the United States. If you look at California, it has the dubious honor of being the state with the greatest number of homeless in it, and New York State follows as the next second. If you look at this, we were always surprised in Minnesota, because I lived 20 years as a young adult in Minnesota, how many homeless there were there, people who were sleeping under viaducts in cardboard boxes when it was 30 or 40 degrees below zero in Minneapolis, with a high mortality rate as well. A severe frostbite would come into the emergency rooms in Minneapolis all the time with literally ice in the extremities and end up needing amputation. So these are a very different kind of experience of homelessness, but similar sorts of issues for these individuals in terms of their needs, what brought them to be homeless, et cetera, as others. And then there's this additional population of the homeless who are somewhat of a new segment since the Vietnam War era came to an end, and we see a large number of veterans who are returning with severe PTSD, who are, for one reason or another, not able to function in society. And the positive thing that you see from this graph is that over the last 10 years, there's been a reduction by 50%, but nonetheless, there's still 40,000 vets out there in the current era who are not functioning well. Up in, Jana, where does Donna ours live? In where? Florida? Yeah, and by the Auburn area, there's a center for vets that does kind of remarkable work for them in terms of reintegrating them and healing some of their PTSD and trauma. So this is a problem, a huge problem throughout society currently. We've got a large number of ex-vets in the Washington, D.C. area who form part of the homeless population. What we see is that about 2/3 of those who are homeless end up being sheltered. About 1/3 of those who are homeless are not sheltered. And of these, we see that somewhere around 1/3 of them are individuals. 1/3 of them, roughly, are families with children typically. And then 1/3 of these are individuals who are just living on the street and unsheltered, representing a significant population. If you think about the 500,000 all people estimates for 2017, that this represents a lot of people who are out there on the street. Society's response to this through the legal system has been one of making being homeless essentially a criminal act. That our justice system, for example, requires money for bail and high fees and fines that are imposed on people who can't possibly pay for them, so there is no option for them but to remain incarcerated. And also the issue of the state restrictions that have been imposed on the homeless in terms of where they can live. I can tell you that this scene in Washington, D.C. would be chain link fence all around this area so that people could no longer camp there. And this started about 2 years ago after we moved to Washington, and all the little camp towns, tent towns underneath the viaducts and the expressways ended up becoming no longer habitable because they had chain link fences. They were overgrown with weeds. People couldn't camp there. Obviously, the number of homeless didn't decrease. They had simply been kind of dispensed or dispelled into the rest of the community, and you would find them in other places, which created safety issues for them as well, because as a group together, they were much better able to take care of one another and fend for themselves. Being homeless has health consequences. Being homeless, for example, on average takes about 30 years off of the life expectancy of an individual. Living as a homeless person tends to age one much more rapidly than other people. This is a study from Boston looking at the homeless, and it compares in the gray bars the different groupings of individuals, the gray bars being those who are not homeless, and the averages for Massachusetts versus those who are homeless. And what you see is this extraordinarily high mortality rate for the homeless compared to the average patient in the society. So these are disparities. I usually say when I give talks that the single greatest disparity in healthcare is being a child, because society does not tend to support pediatric health care and the needs of the young child and family to the same extent that they do the elderly. And this homeless population represents another subsegment, if you will, of society that suffers tremendous disparities in terms of health care. So from the perspective of end-of-life care, hospice, and palliative care for the homeless, one needs to ask the question, what is it that these patients are suffering from and dying from? What we see, I'm hoping this will light up, what we see is that in the modern era, about 1/6 of all the individuals who die, of the homeless who die of drug overdoses. This parallels the societal problem with the opioid crisis that we're routinely talking about. About 1/6 of them have cancer diagnosis, similar fraction with heart disease. And HIV has clearly become something that is much less prevalent in this era than it was 20 years ago or more. And one would have thought that suicide would be a higher cause of mortality than it is, but in fact it's not in this era. This is a historic comparison of the causes of death in the homeless from the late 1980s into the 1990s versus the era 10 years later. And what we see is that there is a significant decrease in the number of patients dying with HIV in the homeless population over that 10-year period, and that there is a much higher rate of drug overdoses and murder in the homeless population. I guess these drug overdoses and these sorts of things will impact how we prescribe drugs for the homeless patients and are part of the consideration I think we all have for opiate use in the palliative care community and world. If you look at palliative care of individuals who are homeless in terms of symptoms, they have a higher than expected symptom burden. The major symptoms that they have towards the end of life include pain, as many of our patients do, fatigue and depression, but to a degree that's greater than we typically see in many of our patients with advanced cancers, advanced COPD or heart failure. The physical symptoms are often associated with significant psychosocial distress, as we know in the palliative care work that one's psychological state tends to amplify or augment the perception of pain, depression, and all of the other sorts of secondary symptoms that are affected by the psychological state. Often there is underlying psychiatric illness, and many of these individuals are distrustful of the healthcare system because of previous experiences they've had with them. The conclusion of this article is that advanced care planning for the homeless requires additional training and skills than we usually use for our everyday palliative and hospice patients. The availability and demand of adequacy for services is enormous because the utilization of palliative care services for lower socioeconomic groups is much lower. Low socioeconomic groups are more likely to use the acute care settings such as the emergency room for their health care needs, and that includes then presenting with terminal symptoms, being hospitalized for symptom management in acute care hospitals. There are very limited respite services and these sorts of intervention services in rural areas in the country where a large number of disenfranchised individuals live. And socioeconomically deprived groups require more resources to achieve the same level of care in palliative care as we would expect from those who are socially more engaged. Accessibility is an enormous problem for people who are homeless because the distance to palliative care services may be insurmountable for them. Bus passes, taxi cabs, Ubers don't exist for the homeless. So the ability to actually access these healthcare services is severely impaired by being homeless. Transportation costs were felt by many of them in this article were found to be so burdensome that they would avoid health care, they would avoid clearly purchasing their medications simply because the costs were too great. And a lack of service in outlying areas forces end-of-life care to take place away from home, which for many cultural groups and for many people would be the preferred place. And yet it's just not possible if you're living on an Indian reservation and you have a terminal condition that needs inpatient unit management. It may not be available on the reservation. It may be 150 miles away in Fargo, North Dakota, or somewhere else. So that there's a large problem with groups where death in the home is preferable. I remember when I was teaching in Thailand, I was told it's bad luck to bring a dead body into the home, and so having the loved one die in the home and lie and waiting at the home while they grieve the loss was the standard. So patients were often discharged from hospital in extremis and transported home in a private rental car because the family didn't have a car. They would hire a taxi or something to get the loved one home so they can die in the home. So location of death we know is a quality indicator in hospice and palliative care. The opportunity for families to discuss preferred location of death is something we consider to be an important part of end-of-life planning for patients in hospice care. And for many of these patients who are homeless, that's an impossibility, which again brings us to the concept of Joshua's house and how important it is. I had sent Kui the handout as a PDF, and I'm hoping that he'll make this available on the website as a PDF for all of you, because a lot of the text that's contained in these slides and that which is grayed out, which are kind of secondary things, but I think important points for you to read, I don't want to spend the time and go over here in detail. They are posted online, so it's a PDF of the whole presentation, and you don't have to take notes. You can look stuff up there and go over it, and the references are there as well in the same way. So if you look at acceptability, I'm going to walk over here because my neck's getting sore. If you look at acceptability and user beliefs, affordability is a huge issue associated with difficulty sustaining the cost of treatments and medications. Out-of-pocket expenses are enormous for low-income groups. And healthcare expenditure tends to be much higher because the symptom burden tends to be higher, and the logistics of care tends to be more difficult. In our patients with medically complex chronic illness, for example, the process of discharging them to home with all of the medical technologies, even when they have insurance, often adds not only days but sometimes weeks to hospitalization. So this is some of the hidden cost of illness when you look at the discharge planning, and is amplified many times greater by not having a home to actually be discharged to. In the adult world, there are subacute care facilities, but getting patients into subacute facilities is often a challenge. And in the pediatric world, we have very few subacute facilities, so getting technology-dependent children home ends up adding sometimes weeks to the hospitalization, and those kids end up staying in ICUs and occupying expensive beds. We need to think a little bit in terms of this concept of trauma-informed care, which is a concept that's developed over the last 5 to 8 years. Is this a concept that most of you are familiar with? People not familiar with it? Yeah, I would say it's maybe a third who are not familiar with it. And it actually was surprising to me several years ago when I stumbled across this terminology. We talk routinely about cultural sensitivity in terms of the healthcare system having an understanding of the cultural idiosyncrasies and the preferences, et cetera, of people. Of course, that assumes that all people in any given culture are all the same in terms of the values and expectations. And I think we know that that's no longer or never was true, but we tend to be lumpers, and we say all Jewish people believe this way, all Catholics believe that way, all Indians believe this way. And that's clearly not true as we expand our concept of so-called cultural sensitivity. But this trauma-informed care really looks much more at the issue of so let's go back one. Non-trauma informed care is most of what we do in Western medicine. Our care focuses on the presenting symptoms without any understanding about the context in which those symptoms developed. In other words, a patient that presents with shortness of breath and is found to have metastatic cancer with significant pulmonary involvement, it's just the biology that we focus on without any kind of focus on the context in which it happens, the patient, the family context. Whereas trauma-informed care really views the symptoms as an adaptation that enable coping and considers the context in which they happen. And this means that all of the diseases associated with poverty, associated with homelessness, often have roots in the whole context and life of the individuals who are presenting to the medical system. And if we don't have an appreciation for their lives and what's gone on leading up to their presentation, we're going to miss a large portion of where we need to focus our efforts. As far as the trauma-informed care, when we think about the homeless, the majority of them have had various sorts of experiences. This is actually from a military publication, uh, obviously Veterans Day from 2009, where this veteran, the soldier, is carrying all of this trauma on his back, all the stresses that he had, and all these things. I guess the metaphor is that it's behind him, but it's still a weight on him as far as that goes. And we see in the type of description of the trauma that the homeless have experienced a lot of the things that we're familiar with, all the way from physical assault, abuse as children. And I think that this is an enormous problem that is under-recognized. In the pediatric world, there's this concept of toxic environmental toxicity, which includes emotional toxicity from abusive parents, includes societal kind of toxicity from choices that children may make, whether it is gender preferences in the high school student or whatever else it may be that ends up producing this sort of trauma emotionally and spiritually that we then see in the 30, 40, 50-year-old coming back to us as we're doing end-of-life and life closure work with them that was never sorted out, but is part of the whole environment they grew up in. The competitiveness of our school system, where if you're not like all the other students, then you're somehow an outlier and you need to get your Ritalin because you can't pay attention in class, or whatever the issues are that end up adding on burden and toxicity to the life of the developing individual. Trauma-informed care, one of the hallmarks is, and we recognize this in our understanding of homelessness in general, is the inability to self-regulate one's emotions, one's behavior, one's thoughts, even one's bodily function sometimes. And we see this in a wide range of patients. And in the homeless population, it's recognized that we need to integrate psychiatric and substance abuse services into primary medical care in order to deal with the issues in some way that doesn't require people to use opiates to numb themselves from the experiences they're having. This is something that I think that even contemporary psychiatry teaching is not, and training is not particularly good at focusing on, because this is a segment of the population that nobody feels strongly they want to spend time with. There are a lot of common themes that I'd like you to look at the handout and go over that many of these patients have had. Early loss is a major theme in many of these homeless people. A lot of experience with death, seeing other people die around them. This is a military person talking about, in 12 months, 13 of us were dead. Fears and uncertainties. I just want to be remembered by somebody. So many of these people are worried that when they die, nobody will remember them. Coping strategies are things that they've all had to develop. A lot of people drink to numb themselves. Harm reduction is an important part of what we try to do with the homeless, and is done in shelter situations. I think that this is a revealing statement. The medical system often says we ask them not to come back either to a shelter or to medical care until they get straightened out or dry out. Well, this isn't going to happen for the majority of them, because alcohol and the chemicals are part of their coping mechanisms to deal with the stresses that they have in everyday life, whether they're real stresses or the imagined stresses. And so to expect them to straighten themselves out before you're going to provide medical care for them is unrealistic. Reconnecting with family. This one person says they don't know me, so why should they have any say in whether I live or die? Not all of these people want to reconnect with their families because early life experiences were traumatic or there was so much disappointment for them. So these are concepts that you should go over. This is a good summary article from Toronto from a couple of years ago that you can find online if you just Google that and read that in more depth. So palliative care needs for the homeless include basic housing. The Joshua's House will provide that. Palliating patients in shelters is difficult because they're often in large rooms. There's no privacy. Hygiene may be difficult. There's a lack of caregivers. Shelter employees are not healthcare providers. They're not caregivers. They're There are people who are trying to provide a safe haven for people to spend the night. Conventional hospice may not be suitable if the substance abuse coexists, and we know that dosage requirements for pain medications in patients with substance abuse disorders are often far greater and different than what we would normally do for our escalating pain management strategies. Programs that are responsive to the culture of the patient. This is noteworthy for people of different ethnicities and backgrounds, and we again try to provide one size and hope that it fits all patients, and it doesn't, because a lot of the spiritual issues they carry are culturally determined. They need to get medications consistently, and that may not be possible, and we need to build that into the system. They need assistance navigating the system. I have enough trouble myself filling out forms and doing things like that, to renew my license and do all the things you have to do, but you muddle through it. Well, these are people who have a lot of difficulty, and they need someone to literally take them by the hand and lead them through the process to follow up on them. What most adult healthcare providers don't quite realize is that when you age out of the pediatric healthcare system, where all of the providers and the system has been oriented towards making sure that you get your follow-up appointments, that if you don't show up, that someone calls and finds out why you didn't show up. Once you age into the adult healthcare system, it's a much more cold and distant kind of experience where you didn't come to your appointment, it's your business. I'm here if you want to see me, so all you have to do is make another appointment and come in. I can tell you that our children who turn into young adults with cystic fibrosis, congenital heart disease, that they've survived childhood, any number of chronic medical conditions, report back to us that they don't want to be in the adult healthcare system because there is generally a distance and a coldness. In fact, my son, who's a medical student at Harvard, looking at internal medicine residencies, said to me a couple months ago, "Dad, I think the whole healthcare system is completely broken." And this is a kid who's got a compassionate heart and just wants to help, and he doesn't understand why we turn bright, inquisitive people into automatons as medical students and scribes as residents, and who are they going to become when they get out and go into practice? And this is a reality. I said, well, if you realize this, then you got to figure out how to change it. I mean, that's the unfortunate reality of realization. So this talk is partly about we need to realize that we need to do something differently. There are successes. You can tell this Sacramento because this is a palm tree or something like that? A mobile care delivery is very effective in going to where the individuals are. Shelters have to be created that tolerate substance abuse. Not that we want to have them be havens for selling drugs or doing those sorts of things. This is kind of the negative side of all of that. We need to engage palliative care services early because, as I'm going to talk about shortly, I think palliative care hospice approaches can provide a lot of emotional and spiritual relief and support for these patients who have spent decades being outside of conventional society. So here's an article from 2009 by one of my colleagues in Washington, Christine Puchalski, who's a palliative care physician and also an internationally recognized expert in spirituality. And most of us were raised in clinical medicine to think that spirituality meant religion. And when we're dealing with issues of spirituality, in the hospital setting, we'll often bail out and call in the chaplain, thinking that the chaplain is the one who can deal with spirituality because they've got that after their name. But that's not always the case. And what we're talking about, spirituality may be a very different aspect of the human experience than theology and religion and that approach to things. This is a definition that Puchalski wrote, which is part of what's called the consensus statement on spirituality and healthcare. I included it here not because I really understand it, but because this is what a standard kind of concept of spirituality is. I find this actually kind of cold and dry. as an understanding of things. I want to think a little bit more broadly. Spirituality, this author says, is part of a holistic biopsychosocial spiritual approach to treating severe mental illness. This is a focus on spirituality. It's a tool for mental illness, and we've already said that many homeless people have significant mental illness. With one of the concepts that we want to create is one of hope, how to sustain or recover a sense of hope even in the midst of demoralizing circumstances. Those are homeless individuals who are diagnosed with a terminal condition. I can remember, for example, when I was a medical student, I worked at the Union Gospel Mission in St. Paul, Minnesota, and I would go there one night a week, and it was precepted by a family practitioner, and there was this grizzly old guy there. He told me he was a sea captain. He told me that he owned an island off Nantucket, and I kept thinking, well, gosh, maybe if I'm enough of his friend, he'll leave me his island in his will or something like that. But clearly this guy was just kind of fantasizing. I asked him, do you have family? Well, I got a daughter, but I haven't seen her in 30 years or something like that. And then he comes in after he'd gotten to know me for half a dozen visits, and he says, you know, Doc, I'm having trouble peeing, and he goes on. And so we're talking about now the late 1970s, long before they had PSAs and things like that. And then the digital rectal exam was the way you diagnosed initially prostate disease. I guess internists don't do digital rectal exams anymore, do they? Not much. I know, it's all PSA. So anyhow, he wasn't going to let anybody examine him, but he said, okay, Doc, you can do it. So he let me do this, a third-year medical student. I didn't know what I was doing, but I could tell that this prostate was really hard. And so I got the preceptor, and he came in, and the guy wouldn't let him examine him. But between the symptoms of my exam, we sent him to the hospital. Of course, he had advanced prostate cancer at that point, and went through all of that. But I can remember how difficult this was, and trying to help him figure out a way to be hopeful and optimistic rather than to just think that, well, this is the end. I had a crappy last, 30 years of my life, and it's just going to get worse from here and I'll die. This is something we need to do to sustain hope. We do this in our regular palliative and hospice practices, but this population, I think, needs encouragement and connection, personal connection to do them. We need to also embrace the concept of life as a journey, our lives as journeys, our patients' lives as journeys. And when you use this as a metaphor for life, then the assumption is that there is always the possibility of change, of improvement. If you invoke kind of the Christian concept that there's always time for salvation up into the very last breath, then as long as our patients are alive and cognitively intact enough to interact with us, we can have an impact on their life and hopefully create some sort of meaningful change and personal growth, that being one of the goals of palliative care, personal growth through a life-threatening crisis. Spirituality is quite important. We need to develop an inclusive understanding that's far broader than just theologies and religion. We need to listen non-judgmentally to understand the role that spirituality is actually playing in the life of the individuals. And we need to build spirituality and comfort with that into our interactions with patients the same way we strive to be culturally sensitive to them. We should be spiritually sensitive and appreciate this as well. Sister O'Keefe, in this consensus document from the Homeless Council a number of years ago, said that homeless people have far more spirituality than we give them credit for. We don't give them credit because we actually don't spend the time listening to them. We don't spend the time talking to them. We don't spend the time figuring out what makes them tick and how these individuals are in many ways more like us than different from us. I think that's one of the issues that we deal with. We need to help them find a quiet and safe place to feel secure, connect with who they are at their core, because self-esteem is a critical issue for individuals who are seeking hope. And then what our approach has been over the last 10 years or so has been to explore integrative medicine techniques as methods for finding a quiet and safe place and accessing the human spirit. And that's what I'm actually going to move into talking about now a little bit. Life closure work, we know already from our palliative care work, but for the homeless, bad death is being lonely, end of life, end of what life? I don't have a life because I'm living on the street. Expressing feelings is important. Basically, that my family doesn't know me, so I won't let them participate in my end of life care. This is a concept that I've been working on and developing now for a few years, which really has to do with life closure work for those who actually can't engage with us. Most life closure work that we do depends upon being able to have a conversation. Is there anything else that's on your mind? Anything that's bothering you, or things that you want to talk about? I do have a few hours. What's on your mind? I mean, we have this conversation, we process this, and then the people tell you, I have a number of examples that I've heard from adult patients I worked with. I embezzled money from my company when I was in my mid-20s, and after a year or two, I left the company, and it's just been on my mind. I felt guilty about it ever since then, and I just wish that I had an opportunity to somehow make amends for all of that, or arguments that people had, or things they had done that they wish they hadn't done. And this lingers with all of us. I can think of many, many examples of things in my own short 68 years of living that I wish I had done differently, but at the time I didn't have the capacity or the knowledge or wisdom or experience to do the way I think I would do it now if I had that same situation to deal with. And our patients are that way, but that requires a verbal discourse. And what do we do for patients who are nonverbal? This can be your patients with advanced Alzheimer's disease and dementias. This can be somebody who's got traumatic brain injury and is a coma in the ICU on a ventilator. It can be a pre-verbal child who can't express where they're coming from. And if we assume that all of us have our own life baggage and issues to resolve and unfinished business, so to speak, in life, why would we think that somebody in a coma doesn't also have unfinished business in their lifetime that they carry with them, but we can't access and we can't deal with it in the same way that we deal with it for the rest of us who are cognitively intact enough to have verbal discourse? And so this has been something that's been bothering me tremendously, seriously. It has been in my last 10 years of both critical care work for children and palliative care work for patients of all ages. How do we deal with a patient who can't express their feelings and unresolved existential issues? Remember, existential suffering is one of the multiple components of suffering that we talk about in the palliative care world. Do we think it just stops existing the moment they become unconscious, or do we think that there are still issues lingering in there that we can work on? I don't have a good answer. I don't read minds. I don't talk with people who are unconscious. I don't dialogue with people who are unconscious because I don't necessarily hear back from them. Although sometimes I get twinges inside of unfinished business based upon the interactions I see between family and patient, and that gives you clues as to relationship issues and things like that. So what I have tried to do is to explore the use of integrative modalities to touch the inner human being, to touch the human spirit. Maybe you can think of it to touch the soul, but at least to get down into the deep part of the human being that carries the existential suffering. And so that's what we've been working on. We've published this. This is a young adult who's had half a dozen craniotomies because of recurrent incurable malignancy, CNS malignancy, and she was racked with excruciating headaches. There were two things that made the headaches go away in spite of all the trigger point injections and the medication she was on. The one was sitting on the bema, the altar at her synagogue, and praying with a mystical rabbi who I knew from Skokie, Illinois, and her headaches would literally go away for 4 or 5 hours after this, just praying. And the other thing that made them go away was when my chaplain, who was trained in Reiki, would work with her and do Reiki treatments, and the headaches would go away for several hours after that. But the praying with the rabbi somehow made the headaches much better, longer. Now, you would think this is just tension or something like that, but I think that it was actually part of the personal presence and the intervention, and it's non-pharmacologic. Why wouldn't we do that instead of adding more drugs to our regimen? Integrative modalities, I think, have an important role because I think palliative care is in a unique position to create these wraparound services. People are not going to laugh at us too much if we bring in Reiki, whereas a surgeon with a post-operative patient on the general surgical ward may say, well, sure, you can bring in the Reiki person. I don't care. It's not going to help. It's not going to hurt. That's fine. But I think we have the opportunity to create a different reality. This concept of holding sacred space for the human spirit to feel safe and heal is critical, because so much of what we see in patients with PTSD is what my Hmong colleagues would call soul loss, the fact that one is so traumatized that a part of one's self, if you will, disappears from reality. And the question is, how do you bring that back? How do you make the human spirit whole so that when death occurs, the individual is complete and has finished the life work? These are the challenges, I think, that we face. And when we're dealing with the homeless, those who are disenfranchised and not into cognitive behavioral therapies, I think we need to utilize other methodologies to touch them on the inside that don't require, again, words or language to do that. You see this quote, which is one that I use all the time, in fact, I was just walking across the street from the emergency room at UC Davis over to the cancer center about 6 years ago with a Hmong shaman from the area who was working with one of my ICU patients. And she said, she said, David, don't you think if we support the human spirit, it allows the body to accept Western medicine more effectively? And this is like a concept that is so intuitively simple and yet obvious that I think that it would be silly of us to ignore it. And so I've tried to build this in both my ICU practice and my palliative care practice. I think palliative care can be an antidote to modern medicine by focusing on the individual, the patient's lives, developing relationships, because we have time to develop those relationships, whereas people who have to generate RVUs in the hospital don't have that sort of time, or busy clinic practices. I think it will help to enhance symptom management as well. We have a lot of experience. You can go through this, but both healing touch, Reiki therapy, massage therapy significantly reduce distress, pain, tension, other upset mood, that these were generic responses. And it's interesting that the family members of the patients actually rate their own degree of distress higher than their loved ones would rate theirs, so that we need to support the families in these situations as well. This is an interesting quote from Black Elk suggesting that we need to have rituals and that we can do to help the spirit transition. That's something that we do with patients when they die. And he says that these rites that they do help to purify the souls of the dead, and our love for one another is increased. So we need to be working from that level as patients are dying in terms of supporting their spirit. I'm going to go through a very brief case here showing how we integrated this into the life of a child with a degenerative disease that Jana and I treated down in San Jose in a chronic care facility. He had been seen at Stanford and UCSF before a diagnosis was made. He ended up having a tracheostomy and ventilator initiated at 10 months of age when he couldn't come off, be extubated after a viral respiratory illness, and the mother realized that at some point she would have to make a decision to end his life. the family consulted with a number of different resources, including the Catholic Diocese in Oakland, Buddhist teachers that they were studying with, reading the ethical literature. And the thing that was most helpful was the work that Jana had done with them leading up to finally taking him off the ventilator. And this was after they made up their mind. This was a picture of them. He's still alive here. He lived for 3 days after coming off the ventilator. This is their Rinpoche, their Buddhist teacher. Father's an attorney, and actually, it was a joyous event letting him go in the sense that the sorrow was counterbalanced by the fact that they felt they had done the spiritual work they needed to do for him to be prepared to let him go. So I'm going to close with this slide and then spend just a couple of minutes on something else. I think that we can answer some of the question of what the meaning of life is. At the most fundamental level, we come to learn and to teach. I think all of us choose our lifetimes because we have things we wouldn't learn if we weren't born into this body in this lifetime, in the families and cultures we were born into, and that the trade-off, the reciprocity for our opportunity to learn is that we teach others through our relationship with them. I think this is also true for the homeless, that the homeless have lessons to learn and lessons to teach us as well, and we need to be open to that for the reciprocity. Do we choose the life we're living? Well, some people think we do. Some people think that there is some sort of, not necessarily predestiny per se, but that there is some sort of choice at some level that the human spirit makes before it comes into a given lifetime. And that what I most want to focus on is the fact that I think palliative care can bring the heart and soul back into Western medicine by caring for patients who can't care for themselves, that we bring compassion, we express what's called grace in the Christian traditions, we bring all of the goodness, if you will, and offer that to patients. And I think no one needs that more than the homeless population that lies so far out of our regular society. There's some resources and extra material in the handout as well. So I'm going to stop here, and I would take 2 questions, and I'll be available afterwards to answer more questions if anybody has any questions, because what I actually want to do is offer you the opportunity for Jana Din to just help settle us all as a group with her drum. She brought her drum here, and she is going to drum for about 8 minutes, if that's acceptable to the group as a whole. Any questions? Yes, ma'am. There is. I can't tell you where the 7 homeless shelters are around the country for the dying. We do not have one in Washington. We have a facility that was developed at the height of the AIDS epidemic for patients dying of AIDS. It's moved a little bit into the direction of homeless patients dying of cancer as well. But it's my initiative with the community-based palliative care colleagues to create such a facility in Washington. I think it's the perfect place for it in terms of visibility at the national level and who we are as a society. I can tell you that in the D.C. area, the community-based hospice organizations, equivalent to your community-based YOLO Hospice and the others in this area, 5% of their budget is expended on care of the indigent, that they designate 5% of the budget for care of those who can't afford to pay for it, and that includes then care in their inpatient units as well. And several of the major community-based hospices have inpatient units of 8 to 14 beds, and they will take a certain number of homeless at any period of time as well. And so I think that's what we have to duplicate. But to have a center that can provide this as a complete wraparound care service for the homeless, I think is important, where we can bring the spiritual part of the healing into them at a level that it may not necessarily be as easy to do in a conventional hospice inpatient unit. I think that that's what a place like Joshua's house is able to do, is to create this focus on the unique needs of the homeless in terms of medications, in terms of the cultural, spiritual, emotional kind of lives they've led, and then to offer them this wraparound service to kind of help usher them out of this life with peace and dignity, compassion, and leave as much of the pain and suffering of this lifetime here, and let them only take into the next, whatever comes next, only the goodness, and that's which is useful to them. So that's my overarching concept of it. So Jana, why, if you want to spend a few minutes?
Actually, do I have? Because I thought this ended at 10.
Well, he ran over with the Joshua House video. He took our time.
So actually, how many minutes do I have? Okay. I can do that. As a high school child development teacher, my life runs by the bell. You're either on time or tardy. So what I would like to do is actually to just have you experience this drumming. I've been doing this for the last 20 years, and I actually have bought a class set of 20 drums for my high school students. So as a form of relaxation for the high stress, anxiety, and depression that my high school students are experiencing at higher than ever normal levels. And for the last 5 years, David and we have provided support, healing support, through this form of drum healing. You could think of it as music therapy in a way. But one of my students this last week, as I was teaching them how to drum, it was a brand new class of child psychology, and my student asked me, he said, how is it that drumming can help induce relaxation, can help calm people down? And I said, well, basically it's moving your brain waves from a beta to an alpha to a theta state, which is very similar to active meditation, but it's a very effective method to use with people that find it either difficult to meditate, don't feel like they have time to concentrate on meditating, or in the case of the patients that David and I have provided this form of healing to over the years, that have no verbal or mental conscious awareness. And so basically it works no matter what condition a person is in, because they're either going to hear it or feel the vibration of the drumming. So what I'm going to do is I'm going to circulate around the room, and I'm going to drum for about 6 minutes, because basically what I have found, not only through research, but also through personal experience, is that it takes about 6 minutes for people to actually have their brainwaves move from that very active left hemisphere state, where they are thinking a million miles a minute and about many different things, to a state where those thoughts, it's like your mind gets put on hold a bit. It has something to do. It's listening to the drumming. But then what's happening is that your mind starts transitioning over to maybe more body awareness, maybe more being just in the present moment. So even though on a very basic level, this drumming can induce relaxation, and actually many people that I drum for fall asleep, which seems counterintuitive, because you would think that if somebody's drumming that it's going to keep you awake, but it actually puts people to sleep. But what it can also do, because of my experience and training and my intention, is that it can assist people in coming to a more heart-centered place, coming to more of what needs to be released from their body, mind, spirit, or soul, without them really having to know what that is that needs to be released. In the case of working with infants or those that might be in a comatose state, it still provides a healing that perhaps we may not be consciously aware of, but in the way that my intention is in working on this level with patients, it still has a healing effect. And it provides me information so that I can be the intermediary between maybe that unconscious patient and their family members. So let's just be in the present moment right now. If you would please, probably it's best if you close your eyes, actually, and not be watching me. And get very present with this drum, the sound, the vibration. If it sounds like I'm drumming very close to you, it's probably because I am. And so I'm going to drum for 6 minutes here. And the intention that I'm going to hold, and you can also hold this intention if you'd like, is that whatever healing you need, mind, body, spirit, or soul, that you actually be open to receiving that at this moment in time. And let's just let that unfold for you, however you may experience that. Are you ready? Here we go. Thank you.